Good morning, everybody, and thank you for coming to this seminar that the University of Valencia and the Fundación Jiménez Díaz organize every month. And today we have as speaker to Dr. Khalid Al-Thihli, that is a medical genetist that works in the University of Sultan Qaboos in Muscat, Oman. He is a physician. He studied medicine in Oman, and for 3 years, when he finished the studies, for 3 years he was working in 3 different hospitals as part of his training as a physician. And then he moved in 2004. He moved to the McGill University in Toronto, Canada, for a training in medical genetics. So he spent 5 years there. After that, he moved again to the British Columbia University for 2 years for a new training in biochemical genetics. After that, in 2011, he came back to Oman, to the genetics department of the Sultan Qaboos University, first as consultant and later on as the head of the department. During these years, mainly during his training period in Canada, he was working in different areas within the clinical genetics, but he is specialized in metabolic diseases, and in fact the center in which he is working is the reference center in this type of pathologies. So thank you, Khalid, for coming. Thank you for being here with us, and I hope to see you.
Thank you very much for the kind introduction. Good afternoon, everyone. I'm very proud and pleased to be here. I promised that I will speak slowly, deliberately. And I was told that you primarily speak Spanish or Valenciano. And so I'll try my best to make my English language easier to follow. If it happens to be by accident that any of my colleagues happens to watch this presentation, they will know that this is not me, not because of the way I dress, but because typically I am very fast when it comes to giving presentations and talks. I just try to give too much over a short period of time. Having said that, I must highlight that I'm extremely happy and proud that I am now standing in this historical university, and I've learned a lot through the generous invitation of Systemas Genomicus to attend this platform. I've learned a lot about the city, I've learned a lot about the organization, and today I have learned a lot more about the university. It makes me feel sorry that I haven't been part of this university as a medical student, but maybe by then I would have lost the ability of standing here speaking in English, as I will be picking up maybe some Spanish language as opposed to English. So today I will be talking to you about a study that basically originated out of our own local experience dealing with patients with inborn metabolism. The study is now published, and for those of you who have difficulty following the English language, I think it is translated into Spanish. It is entitled The Clinical Burden of Inborn Metabolism in Oman. So after the disclaimer of thanking Systemas Genomicus for being here, I thought before we head into talking about the main talk, I'd rather talk to you about Oman. Because I don't know how many of you knows where Oman is. I guess some of you may not have heard about the country before. Sometimes this is a good sign, because that could say that it's a peaceful country, it doesn't make noises. So on occasions it says also that it might be a small country, which is true. So where Oman is located, so it's a small country that is located over here. It's in the southern eastern part of the Arabian Peninsula. It is bound to the north by United Arab Emirates. To the south, it is bound by Yemen. And to the west, it is bound by Saudi Arabia. Definitely would have heard about Saudi Arabia and Yemen, but may not have heard about Oman. So it was a long journey for me to come all the way from here into there. But it's definitely worth it now that I've experienced being here. Okay, so what you may not know about Oman is that Oman is still a beautiful country to visit. So this is what characterizes the country, is that it has got a lot of diversity when it comes to nature. You could actually find people living on the shores with mountain hugging the beaches and Corniche. And you could also enjoy being in the desert if you like to go out walking in the desert one day, so sand walking. So that's a very contrasting diversity that you may not see in any other Gulf country within the Arabian Peninsula. You could see mountains submerged in the sea, and you could also see turtle reserves and watch baby turtles walking into the sea. We also have an oryx reserve that is part of the Omani Peninsula. Oman also embraces history, and it is a country of that dates back to thousands of years. And this is one of the forts, one of many hundreds of forts that we have in the country distributed throughout the whole geographical region of Oman. But we also embrace modern structure like as it is displayed in this Royal Opera House that was constructed not too long ago. And if you like major concerts, then you better check the website of the Royal Opera House when you decide to visit Oman one day. It's not about dry country that doesn't have anything that is green, because this is what we call, in an English translation, the Green Mountain, which is Al-Jabal Al-Akhdar. So the Green Mountain is not the only mountain that is green. We also have widespread greenlands in the southern part of Oman during the months of July and August, which is very surprising to someone who lives in the Arabian Peninsula. But that gives you a hint of the diversity of the country, even when it comes to the climate and weather. This picture is from the southern part of Oman, which is the region of Dhofar. Now, the region of Dhofar is of particular interest to someone who is interested in archaeology, because this region of the country in this publication was the first region in the Arabian Peninsula that has shown evidence of out of Africa migration across the Arabian Peninsula into Asia. Those Nubian complexes that were discovered by Jeffrey Rose not too long ago, that were found in the region of Dhofar, which is the southern part of Oman, were only found in Africa and along the Nile River and in this part of Africa here, clearly establishing a link based on dating that they actually dated back to the first waves of migration out of Africa into the Arabian Peninsula and then into Asia. So that's Oman for you from one standpoint. Now moving back into the study, this is the title again. This was a product of collaboration between two different sites with, again, interested young clinicians. So as you can tell, I'm not really a very old one, I hope. And I got back from Canada not too long ago. So I actually got back from Canada in 2011 after I finished my biochemical genetics fellowship training. The first question that hits your mind as you join back providing a service, especially if it has not been very well established, is okay, well, how I am going to plan my resources, plan my strategy of treating and managing patients, human resources required, what sort of practical objectives I need to achieve over the short term and long term. In order for me to answer many of these questions, I need to have some data available. So, and unfortunately speaking, the service of Inborn Metabolism before we joined was taken care of by one single physician, a pediatrician who picked up interest in inborn enzyme metabolism, but he was alone, he was the only one. We didn't have a comprehensive database available, so we thought maybe we could look into the literature that was available at that time, that published something about patients with inborn enzyme metabolism in Oman. So we went back and checked some of the available literature in the world. So this was a special edition that was published by the Center for the Arab Genome Study, or CAGS. Was a special edition about the genetic disorders in the Arab world, and in that special edition, the focus was Oman. Unfortunately speaking, many of the disorders of inborn metabolism were very loosely defined. Patients were not truly biochemically or enzymatically or genetically confirmed, and most of them had a clinical label, except for the patients who were diagnosed on tandem mass spectrometry or mass spectrometry. So those ones had some sort of biochemical evidence of the diagnosis, but to a large extent, the data that was available on that edition was not comprehensive, and it certainly wasn't entirely reliable. So we looked back into other literature that was available, and these were two publications that came describing the pattern of inborn enzyme metabolism among Omanis in the Arabian Peninsula. And both papers were published by the same physician I told you earlier about. The only problem, again, goes back to what I have described earlier about the limitation of defining those disorders. The second major limitation is that this was a single center experience that did not necessarily shed light onto the magnitude of the problem across the whole country. A more recent paper recently published in the journal Community Genetics wanted to evaluate, or aimed at evaluating the burden of congenital and genetic disorders in Sultanate of Oman. But at the same time, this was largely driven by a morphologist, and the inborn enzyme metabolism were not given the magnitude and significance they deserve, at least in this paper. So there's a clear need for us to do some extra work understanding the clinical burden of inborn enzyme metabolism in Oman. We knew this because most of them are recessively inherited. And we also know that recessively inherited disorders tend to occur more frequently in highly consanguineous population, of which Oman is one country. So Oman has got generally high rates of consanguinity. Consanguineous marriage is still prevalent in the country. According to the National Health Survey in 2000, nearly half of the marriages occurring in Oman were actually consanguineous. So that is marriage between second cousins or closer. So that's a relatively high percentage. In another clinic-based study, this sort of similar findings were replicated. Almost just above 35% of marriages were between first cousins and second cousins. We also know from other publications that wanted to shed light on the consanguinity rates in the country, that the rates have not really changed dramatically over the past 4 decades, despite significant changes in the education levels of families and couples. The tendency towards consanguineous marriage is still prevalent. It may drop as low as 20% in some areas, but it may be as high as 50 to 60% in other areas. So it is a significant issue in the country, and it is a significant factor that has contributed to that apparent increased prevalence of inborn enzyme metabolism in Oman. We also have published we've described in a poster in the last International Congress of Inborn Enzyme Metabolism in Barcelona the results of a pilot study that screened nearly 1,800 newborns unselectively for 24 different treatable inborn enzyme metabolism detectable on tandem mass spectrometry over a period of about 10 months. And we've diagnosed 3 new patients with small molecule disease. So 1 with propionic acidemia and 2 with maple syrup urine disease. So clearly, so giving an estimated incidence of about 1 in 600, and that is not too far from the figure in the neighboring Arab countries in the Arabian Peninsula, and certainly among the highest we've seen being reported across the whole world. So it is that's a major burden that we have to deal with. So we got together with colleagues in the university. There's another colleague of mine who shares taking care of patients with the inborn metabolism. And we also cross-talked with another colleague in the Royal Hospital, which is the other tertiary hospital in Oman, who is taking care of patients with inborn metabolism. And we thought there's a need to assess the clinical burden of IEMs, referring to inborn metabolism in the country. We wanted to evaluate the prevalence of consanguineous marriage among families with inborn metabolism in the country. We actually were a little bit opportunistic because at that time we were invited to write a part of an editorial publication about consanguinity in a special edition in Human Heredity, and that was the task that was assigned to us. So we wanted to shed light on that subspecialized area of genetic disorders, focusing on inborn metabolism. So it was a retrospective study that involved the only 2 tertiary sites in Oman that take care of patients with IEMs, and that is the Genetic and Developmental Medicine Clinic at Sultan Qaboos University and the Metabolic Unit at the Royal Hospital, which is the other government hospital that is providing this service to patients with IEM. So we've included all patients with inborn metabolism who were biochemically and or genetically confirmed, but should have genetic confirmation. And we have reviewed all the clinical records available for the patients with confirmed diagnosis of IEM. The consanguinity rates were calculated based on the family history that was gathered as part of the clinical records reviewed. So I'm sorry that this is a congested table, and it's probably showing some congested information. I'm not going to go comprehensively through every single one of them, but I would shed light on a few observations. One, it's not surprisingly the most commonly diagnosed group of inborn metabolism in our cohort are the amino acidopathies, or disorders amino acids metabolism. And it's not uncommon, largely because amino acidopathies, especially the ones that we have described in this cohort, would be the patients that would become easily recognizable by the pediatrician, and they would refer these patients for clinical assessment early on because they behave in a sepsis-like picture, but they don't respond to conventional treatment of sepsis. Or they may have been encephalopathic out of proportional to what the pediatrician may anticipate. So we've become involved in more and more in evaluating patients with amino acidopathies, and they constitute a major group of disorders that we deal with in our clinic. The commonest amino acidopathy, and sometimes considered also an organic acid metabolism disorder, is maple syrup urine disease, and I think that's entirely attributed to a founder mutation. We currently treat nearly 35 patients with maple syrup urine disease in one center, so 35. Such a number that outweighs the number of maple syrup urine disease patients I have seen throughout my 7 years of residency and fellowship training in Canada. Again, signifying how important this is. We also see a variety of other amino acidopathies. The second group of disorders that we deal with are organic acid ureas. We also have a significant number of patients with glycogen storage diseases, the commonest of which that we encounter in our clinic is glycogen storage disease type 3, a number of fatty acid oxidation disorders. The lysosomal storage disorders constitute another group of disorders that we deal with, and the commonest lysosomal storage disorder that we see is mucopolysaccharidosis type 3. Unfortunately speaking, it's untreatable, but we have other disorders, other patients with treatable lysosomal storage disorders with enzyme replacement therapy as part of the cohort. mitochondrial disorders. This was an underrepresentation of the number of patients with mitochondrial disorders that we see in our clinic, primarily because we have limited number of patients who are genetically confirmed to have a mitochondrial defect, and some of them had been underworked as far as biochemical evaluation is concerned. So, but we, at least you could see from the presentation here, is that out of the 12 patients confirmed with a mitochondrial disorder, 8 had nuclear defects, and 4 of these patients, which is nearly half of the other number. So 4 of them had nuclear defects, and all of these were recessive. Again, highlighting the fact that consanguinity still also plays a role when it comes to the distribution of mitochondrial disorders in our cohort. All right, there are other less common transporter defects that are seen in our clinic, and that's a general pattern that is seen in other clinical cohort groups as well. So back to what we have seen in our study. This shows you the distribution of patients with inborn metabolism that we have diagnosed in this study, and the gender distribution in Oman is 50-50, so like we have 50% females and 50% male. There's some overrepresentation of males in this study, and I think it's and that's not because we have X-linked disorder or patients affected with X-linked disorder in our cohort. We only had 3 patients with X-linked disorder, but there's a tendency for some reason for males to be more severely affected, generally speaking, among many inborn metabolism, and this observation actually seen in other examples of even in recessive conditions. An example would be, for example, the patients with recurrent rhabdomyolysis and that are caused by fatty acid oxidation defects of the long chains. There's a tendency for males to be represented more than females, and overrepresentation of males for reasons that are not entirely known. But we're expecting that the percentage is going to be more or less the same. I wouldn't expect that there would be significant differences. Not surprisingly, most of them were made within the first cousins. So the consanguinity history was collected for nearly 240 families, and the major proportion of these couples were married within first cousins. We don't have any incest in the society, because that's forbidden. But we do have, of course, first cousin, second cousin marriage. Second cousin marriage happens to be the second category of preferred marriages in the society, and then we have double first cousins as well, shooting about 2%. So they are usually related from double size, dad and mom, and then the 1% of them represent first cousins once removed. So clearly, very high rates of consanguinity, and the preferred first cousin marriage is something that is very popular within the society for some reason, largely historical. This is another map of the country, getting a little bit closer, shedding a little bit more light on the distribution of patients, the number of patients across the different regions of Oman. The numbers that you see designate the various regions. You could call them provinces or states in the country. So these, and we call them regions. So the numbers that you see in bold is basically a designation of the region. I am not going to walk you through every single number or digit that I'm showing, but I want to draw your attention to 3 main observations. The first one is that most of the patients that we see in our clinic, so nearly 3/4 of them, come from 3 main regions. So that's the Al-Batna region, Muscat, which is the capital, Al-Batna, Muscat. Muscat is the capital of the country, and then Al-Sharqiyya. So this region number 6, that's where the major pool of our maple syrup urine disease patients come from. They come from this region. Our major pool of fatty acid oxidation disorder patients and patients with ketone utilization disorders usually come from this region, region number 3. We also have a number of patients with amino acidopathy that come from this region as well. Region number 3 is Al-Batna region. Muscat represents more of a heterogeneous population that has pooled from different states, because a lot of them are not really from Muscat, which is the capital of the country, but from other regions of Oman, but they have migrated into the capital because of work-related reasons. But clearly, there's an underrepresentation of the rest of the region of the country, because we have nearly almost most of our patients coming only from three regions of the country, but not from all the regions of Oman. Another thing that is very concerning is that a population of nearly 45,000 wouldn't have in the Worcester region, and we don't have a single patient with an inborn metabolism that comes from that region. So it's clearly very concerning. This is more of a desert based region. A lot of them, it's distant from the capital, from region number 9. So we would expect that it would be difficult for them to travel for evaluation. A lot of no-shows in our outpatient clinic are from this region. And the least number of physicians talking to us for consultation about suspected inborn of metabolism come from this region. So it's fairly concerning that we don't have any patients with this group of disorders coming from this region, because that clearly says that some of these patients who might potentially benefit from therapy are not being recognized, are not being diagnosed. This is compounded by the fact that we do not have an existing newborn screening program, at least at present time, although this may change hopefully in the very near future. The third observation that I want to bring your attention to is that region number 7, which is in the southern part of the country, the region of Dhafar. This region, although we have diagnosed patients with inborn metabolism, which is nearly about 22 patients, none of the patients with inborn metabolism diagnosed from that region of the country has got a small molecule disease. None of them has got an intoxication type of disorder, except for non-ketotic hyperglycemia or glycine encephalopathy. And unfortunately speaking, the one that we have is the classic non-ketotic hyperglycemia, where the benefit out of therapy is rather limited with a combination of sodium benzoate or glycine-reducing therapy and NMDA receptor antagonism. Most of them, they don't really respond to this therapy, and they run very poor prognosis. But the disorders that may benefit from intervention, like small molecule disease that may present with acute intoxication type of presentation, the amino acidopathies like maple syrup urine disease, or the organic acidopathies like propionic acidemias and methylmalonic acidemia, none of these patients come from that region of the country. So it's very surprising. We know that they must exist because we have inhabitants from the southern part of the country who have moved into the region of Muscat for work-related reasons, and we have diagnosed patients with arginase deficiency, urea cycle disorders in this family. So clearly says that they do exist, but they are not being diagnosed. So again, another reason to mandate consideration of a newborn screening program sooner than later in the country. So these were the main observation cross-sectionally out of the patients we have seen. We also looked into another factor that usually confounds the management of these patients and families, and that is the presence of another comorbid condition along the diagnosis of inborn metabolism. And 17 patients out of the total number of 286 patients that we had in our cohort, 17 had an existing comorbid condition that cannot be explained by the underlying inborn metabolism. And 3 of them, in fact, had another recessive condition inherited. So we have a patient with glycogen storage disease, type 3, who presented to us with recurrent pancreatitis, despite the fact that she was reasonably under appropriate control and she had triglycerides within acceptable range. but she had evidence he had recurrent pancreatitis. And upon evaluation of the fact of the causes of recurrent pancreatitis, she was actually homozygous for a cystic fibrosis causing mutation that has predisposed her on top of her existing condition to recurrent pancreatitis that is evolving into chronic pancreatitis as well. We have another child who has got isovaleric acidemia, but on top of the isovaleric acidemia, she also has coexisting cystic fibrosis. We have a child with another inborn metabolism that has got co-inheritance of an autosomal recessive form of oculocutaneous albinism. So what I'm trying to say here is that the power of consanguinity is such that also presents you with another challenge, which is that sometimes you could face a patient with a classic or typical inborn metabolism, but every now and then that patient presents with another atypical complication or unusual complication that is seen that should really prompt you to consider another recessive etiology that is really implicated. And it's something that has, for a long period of time, has been neglected, but it's at least in our center, but a lot more light is being shed into this particular aspect of management of these families. And as we go along, we started learning more and more about these examples. So genetic diagnosis until not too long ago wasn't really something that is mandatory, because in the past or before we joined geneticists, the exploration of potential available avenues for prenatal diagnosis or pre-implantation genetic diagnosis, these options were not being explored or discussed with the families by a general pediatrician or an internist, either because they didn't have time or maybe ignorance. I don't know what the reasons were, but clearly they were not being discussed. And since you do not discuss the option of prenatal diagnosis and prevention, primary prevention through, for example, PGD, then you seeking a genetic confirmation as a physician, the drive for it, if you have a clinical diagnosis, becomes less prominent. But ever since we joined, we thought this is a mandatory step in order for us to improve the aim towards primary prevention and maximizing the chance of reducing the prevalence of these disorders in the country. We made an effort to aim at establishing a genetic diagnosis in every single patient with genetic disorder and with the inborn metabolism that we see in our clinic. Even those ones who we consider to be treatable, because that also expands, not only for we're doing it because that should really sort of be the comprehensive aspect of our work, but it's also because it has a direct clinical relevance to the patients. That's one avenue through which we got to know also systemic genomics. So causative mutations in our cohort were identified in about 127 patients. And not surprisingly, again, because of consanguinity, nearly all of them were homozygous. So it was extremely unusual that we see a couple where the recessive disorder is caused by compound heterozygosity. We do have one single exceptional example, though, in our cohort with Gaucher disease with compound heterozygosity. It happens to be also that one of the parent was also a carrier for two disease-causing mutations in cis. So within the same family, we have seen both homozygosity and compound heterozygosity within the same family. So that's, sort of genetic counseling students who are rotating in our clinic, they find these are fascinating observations. So out of the 42 different mutations that we have identified in our cohort, 9 mutations were shared by 2 or more unrelated Omani tribes. Oman is an Arabic country, and especially within the Arabian Peninsula, it is a tribal country. So one tribe actually could constitute a large number of individuals who share the same tribe, family name, if you'd like to say. And that tribe has originated originally from a small number of individuals and then has expanded eventually. And you could see the same tribe in more than one region of the country. they could be or may not be genetically related, but historically they could actually come and have originated from different regions of the country or even from outside the country. But it's, the country is established in such a way that it is primarily tribal in distribution, tribal in organization. It's built on tribes. And if it's unusual to see that the same rare mutation causing a rare disease, that it is being shared by more than one tribe. So, and if we do see that observation, that mutation is being shared by more than one tribe, that clearly sheds light on the very high likely possibility of the mutation being of a founder effect. And there's one family that we've seen this example across a number of families. I can recall this mucolipidosis type 4 family I was talking to you about earlier that has shared mutation with another, a completely unrelated tribe, but they come from the same region. Again, and now the hypothesis as to whether this is the same haplotype that is being shared by the same family is being evaluated to assess whether this was truly a product of a founder mutation. So here comes to my last slide, and I just wanted to keep it in time. So inborn metabolism are still under-recognized in our country, especially that we don't have an expanded newborn screening program available. A lot of education efforts are to be carried out to improve this, because I think they would remain underdiagnosed unless that knowledge about and recognition and consideration and index of suspicion is disseminated appropriately throughout the whole clinics and various clinicians of various sectors. Consanguinity likely has significant contribution to the apparent high prevalence of inborn metabolism in Oman, and we've seen example through this study to demonstrate that very likely we do have the effect of founder mutations being seen as displayed by the same rare mutation being shared by 2 or more different tribes in the country. That brings my presentation to the acknowledgments slide, and I want to thank my colleagues, Dr. Fathia Al-Murshidi. She is I'd like to call her the senior biochemical geneticist. She came 1 year before me, and she started the taking care of organizing for the clinic to get started. Subsequently, we now are we are jointly taking care of patients with inborn metabolism, Sultan Qaboos University Hospital. Dr. Nadia Al-Hashmi is another colleague of mine who has started establishment of the biochemical genetics service displayed in the metabolic unit at the Royal Hospital. Professor Saeed Yahyai provided data from his study evaluating various mutations causing inborn metabolism in the country. Asila is our metabolic nurse. She's been playing a major role in taking care of these patients, and then Maria helped in data collection. That's it for my presentation. This is another picture of a valley from the country. Valleys are unique in Oman. Unique in other words that you don't find them in other Arabian peninsulas, but it's actually more of a relatively common scene that is seen in our country. That's it for my presentation, and thank you very much. I welcome any questions or comments.
Okay, thank you very much, Khalid, for your nice talk. Well, thank you also for speaking slowly. We appreciate your effort, and thank you also for introducing us in your country. Fortunately for you, until now it is not a touristic country. Okay, questions?
Hi, doctor. First of all, congratulations for your very nice presentation. I would like to ask you if you think it would be a good idea to extend a general mutation panel for carrier status, like a preconceptional panel for mutations in your populations. Would that be possible in your health system status? And would that benefit the couples?
I think this is an excellent question. It's burning, and we've thought about it thoroughly ever since we started. We actually, as I've said earlier, this area still is largely unexplored. Our knowledge about our population genetics is still limited. The frequency of various mutations is still not well comprehended. We have characterized the frequency of some common mutations reasonably well, with some of the more common disorders like cystic fibrosis and maple syrup urine disease. But for the other rare disorders, it's not fairly common. It looks like mucolipidosis type 4 is another disorder that may have a founder mutation, or maybe a limited number of mutations that are seen. So yes, for many of these disorders where a small number of mutations, where allelic heterogeneity is not extensive in our society, they would be the very good candidates, depending on the type of disorder, the severity, availability of treatment, and other parameters. They would be the best candidates to, for example, try to simulate the Ashkenazi Jewish panel, for example, for carrier testing and premarital screening. At the present time, we have been focusing on gathering more information about the type of mutations available, the distribution of these mutations, the more common disorders that we have to address depending on our priorities, and then their geographical and demographic characteristics, because there are some disorders that are more common in some regions of the country, again linked to the distribution of that mutation. So eventually that panel may have to be tweaked in such a way that is designed to be offered, for example, a specific panel for that specific region. I think we are at a very early stage of deciding about how the panel should look like, but it's definitely something that we are considering seriously. It is something that may be extremely useful for hematological disorders like hemoglobinopathies in our country, because hemoglobinopathies have been largely characterized. At the present time, many of the significant proportion of the families know that they can be screened for their carrier status, but it is being done biochemically. So an individual would go and should have a blood collection done before they plan on getting married, but they would be suspected only to HPLC. Now, for basically determining their carrier status for the thalassemia or hemoglobin S or other forms of alpha thalattates. That method has got really, it's not really 100% sensitive and specific, and sometimes it is operator dependent, which makes it really sort of, but they have, in the hematology department, they managed to characterize patients with hemoglobinopathy genetically very well. So we know the more common mutations available. Sickle cell disease is only one. The alpha thal is more heterogeneous, but at least for the beta thal mutations, we have a limited and a small number of mutations. It could certainly be incorporated within a panel, and I think that would be probably the best model to get this incorporated. As we speak, we are still building knowledge about those mutations, and it's definitely something that we are keeping in mind for the sake of introducing to the society as a whole for primary prevention.
Okay, in this line, so for example, in Europe, there are some national programs that wants to detect earlier genetic defects or other type of biochemical diseases through a national screening program in newborns,
right.
For example, phenylketonuria.
Yeah.
So in this way, is there any similar in your country for this specific pathologies, or even for cystic fibrosis, because I suppose that cystic fibrosis is a candidate disease for this type of studies or screenings?
Yeah, so this was the bane of our lives. We actually, as soon as we came back from Canada, we had a dream of hopefully being able to get the expanded newborn screening program established for treatable disorders. That includes small molecule diseases that are screenable by tandem mass spectrometry, cystic fibrosis, maybe even help our colleagues in hematology to get the hemoglobinopathy screening incorporated within the same newborn screening program. We also are talking with our colleagues in immunology for immunodeficiency, because There are some disorders that are very much treatable with the BMT, like should be combined immunodeficiency, to be incorporated within our newborn screening program. And it has one of the major tackles, one of the major challenges to this intent to come into reality is the fact that we've been rather limited in terms of the number of physicians available to take care of these patients. And the government wanted to see significant evidence of success from the same region. If you look, unfortunately speaking, into the nearby countries when it comes to newborn screening programs, the program has, for example, in the country with the largest experience in the Arabian Peninsula, Saudi Arabia, the program has not been very successful in terms of prevention of significant morbidity of these disorders, largely because of failure within the system and the organization, sometimes delay in reporting, delay in recollection. So that defeats the whole purpose of newborn screening programs, and governments and the decision makers want to see a clear role model that actually could be subjected to implementation and reality in our country with potential room for success. Now, with this limited number of physicians, it is a constraining factor, but we have provided a pilot that is now actually still in development and revision, in order to have hopefully the newborn screening program expanded, being implemented in the country hopefully soon. So it is being thought about extensively, but we'll definitely need some more staffing. We'll need more dietitian. What I haven't told you about our major limitation is that despite this extensive number of patients with small molecule disease, some of them require micromanagement of the dietary management. Despite all of this, we only have one single metabolic dietitian in our center. A lot of us as physicians work as dietitians. Sometimes if she goes on leave, we will be the consultant biochemical geneticist. We will be the one who rounds on patients, and we also will be the dietitian who calculates basically their formula. So it's understaffing the limited number of expertise available is a major challenge. We recently recruited another dietitian to help in the management of these patients. But definitely, if we are going up the window for an expanded newborn screening program, we are putting our hands in a bag of worm, and it's very likely that we will have more and more of these patients coming up, because the ones that were not recognized based on clinical index of suspicion are now hopefully going to be caught by the newborn screening program. So we will be expecting the numbers to go up, because the fertility rate has not changed dramatically. So it is going to be continued the same, and we'll probably need some more staffing. So all of this is being incorporated in planning and thinking about how we are going to design the pilot for the newborn screening program. Yeah.
Okay. Bueno, un poco resumiendo las dos cuestiones que estaban juntas, el tema es que han preguntado por la posibilidad de hacer paneles con mutaciones específicas y aplicarlas al diagnóstico debido a la consanguinidad que existe en el país. Entonces, pues sería algo realmente pues muy útil y práctico, ¿no? En ese sentido, lo que contestaba Khalil es que en estos momentos que efectivamente es algo que se tiene en mente, que están tratando pues de recoger la mayor parte de información de las diferentes enfermedades, con la idea no solamente de las diferentes enfermedades, de la incidencia de determinadas mutaciones concretas y específicas, sino también en las diferentes regiones del país que ha mostrado en uno de los mapas. Y que, bueno, que con todo eso, pues la idea es que se pueda generar en algún momento un panel con una serie de mutaciones que vayan dirigidas a las enfermedades más específicas. Y luego también, engarzando con esto, pues si existía algún programa de tipo nacional para la detección precoz de otras enfermedades como fenilcetonúria, que por ejemplo son enfermedades curables y tratables desde el momento del nacimiento si se conoce el defecto mediante un tratamiento sencillo, o bien enfermedades como fibrosis quística, pues que deben tener también alguna mutación fundadora que explique la mayor parte de los casos. Él comenta que en estos momentos todavía existen problemas administrativos por las experiencias de otros países en cuanto a temas logísticos fundamentalmente y administrativos, pero que es algo que obviamente que se tendrá que ir implementando. Entonces, de forma muy resumida.
Whatever he said is right.
Okay.
After you diagnose a recessive condition in a couple, in general, couples ask for prenatal diagnosis, or is not an option for many couples in Oman?
Very good question. And these couples are classified into two. The younger generation couple, the more educated ones, they would ask. So they would be like, what would be our options? The older generation couples, they would be like, why did you test us overall? You know, we would have already consented them for genetic testing, but they would be like, why did you test us? You know, and then so it takes some time during counseling to give them the potential benefits of the genetic confirmation, not only for them, even if they stop their pregnancy, but for the other siblings. They are actually brothers and sisters of a child affected with a recessively inherited conditions, so they have a 2/3 risk of being carriers for the same recessive alleles. So they, when we get into that discussion, and we get into the discussion of talking about prevention, then it changes the picture completely. Initially, one of the very common observation that we have encountered and we continue to see is that they tell us that we are going for second opinion. Second opinion because we told them that this is a genetic condition that is untreatable. So they'd be like, okay, no, send us to Europe or elsewhere. Okay, well, Europeans told me, as someone who got trained in Europe or America, that it's untreatable. And if they publish, I'll see this online. So, but it's very difficult to get the family believe me, unless they hear this from someone else. So, so the older generation, a lot of them would go out and seek another note or observation or prognostic statement that is different from mine. And eventually, if they hear the same statements, again, they'll bounce back. And then they are more receptive of learning about options for their children now. Because this is an untreatable condition. Child has got primary microcephaly, was already confirmed to have a cardiac Gautier syndrome. There's nothing much you could do about getting this brain to grow. Fortunately speaking, it has got extremely poor prognosis. Takes time from them until they believe. But eventually, once they understand that there's something that you can offer in terms of prevention, the whole picture changes completely. But it actually sort of, sometimes the denial phase takes longer than expected, and sometimes they don't really become receptive except with repetitive counseling. Yeah.
So I understand that the prenatal diagnosis then is permitted in your country in the untreatable diseases. Right.
So we don't have an existing rules governing what sort of disorders are to be considered for prenatal diagnosis. But what our clinic has adapted general criteria for disorders that we should recommend for prenatal diagnosis in those families considering pre-implantation genetic diagnosis, because that's not a procedure that is being done locally. The government would have to pay for the couples to travel abroad for pre-implantation genetic diagnosis. The option of pre-implantation genetic diagnosis, like anywhere else in the world, gains preference in couples who are worried about intervening with life. In our country, which is a Muslim country, the religious scholars have divided themselves into two major groups. One says life begins at 40 days post-fertilization, and another school of scholars of religious groups says that life begins at 120 days post-fertilization. At 40 days, there's no way that sometimes a woman knows that she's pregnant. Most of females are like, okay, what happened to my period? It's delayed this month. So, so those couples who believe in the 40 days life beginning would go for PGD. So that necessitates that we get them sent abroad for PGD, for the IVF procedure and PGD. But we would have already completed the genetic workup, of course. So confirmed, for example, that this is a homozygously affected child with a recessive condition We also confirm the career status of the patient so that we don't get confounded with the fact that there could be a deletion. So we complete the genetic workup that is related to the couples and required. And then we ask for them to be sent abroad for treatment. Usually we have done that with conditions that are considered to be severe, untreatable, in families with confirmed conditions, of course, after the genetic disorders being completely worked up, no available intervention, associated usually with shortened lifespan, and for which no treatment is now presently in development. So these are the main disorders that we have considered. And also in couples that have got a small number of children. So in other words, we tend to back off from recommending this for couples who had 7, 8, or 9, largely because the government is saying, the Ministry of Health is going to tell us, well, they had already 7 or 8 or 9 children, so maybe you could advise them for something against them getting pregnant as opposed to having more children. So we tend to sort of tend to argue in favor of supporting a family that has not yet attained the average family size of an Omani family, which is about 5. And there are some unfortunate children, unfortunate couples and families where their odds have beaten all consanguinity-related risk calculations. So I had families with 3 children, all affected with propionic acidemia. The couples, every single time you tell them our occurrences is going to be 25%, that 25% to them has become 100%. They became pregnant 3 times and all of the children affected with propionic acidemia. So those sad examples really are the ones that shed light on the immense need for PGD or prenatal diagnosis in order to prevent especially those severe disorders from happening. So, and I'm very glad to say that we did have families who benefited from prenatal diagnosis and from PGD. So it is something that is becoming more and more popular among couples with genetic disorders, and I've already seen the first very positive signs about this interest in the society.
And is contemplated the age of the mother, older age, for example?
Yeah.
Yes.
Yeah. So most of the time, by the time most of the women in Oman would tend to marry early, so they would get married maybe in their 20s. I've been an exception. I was telling you, I've been an exception. I married late, but most of the time, people would have married in their 20s, and by the time they are in their 30s or 40s, they would already have had 8 or 9 children. Mm-hmm. So the younger generations have now an average family size of about 4 to 5. So especially the ones who get married late. So by the time you're dealing with a couple, with older woman, in that age, usually she would have had 7 or 8 children, and then we would advise her not to consider getting pregnant anymore. Mm-hmm. A lot of the couples come proactively making that decision after having 2 or 3 children affected, especially if they have other normal unaffected children in the same family. Mm-hmm. Yeah.
Bueno, se me han olvidado ya algunas cosas, pero más o menos resumiendo y empezando con la pregunta que hacía el doctor que tenemos en la sala sobre el asesoramiento genético en diagnóstico prenatal de enfermedades consanguíneas, metabólicas en este caso, cómo funcionaba, cómo respondía la gente, etcétera. Pues la gente joven en principio se preocupa y está interesada en el tema. La gente mayor, cuando le habla de los problemas que conlleva, que tendría el proceso que tendría que seguir y demás, pues que muchos de ellos lo que piden, una segunda opinión de alguien que incluso les va a indicar otro camino, pues que si existe posibilidades de curación o de mejoría, etcétera. La gente mayor sigue siendo reluctante a estas situaciones. Y luego, por otro lado, con respecto al gobierno, tampoco hay una legislación ni una regulación exacta. Bueno, es una situación un poco complicada, pero es lo que en estos momentos tienen todavía, y la gente joven pues cada vez va solicitando más estos servicios, básicamente. ¿Alguna otra cuestión? Okay. Karim, pues thank you very much for coming. Thank you for your explanation.
Thank you very much.